Good morning. It's great to see everybody. I know it was a big night last night. A lot of people are flying out tomorrow, so it's probably the night to go out. But we really appreciate you being here. Thanks for joining us this morning. I'm Tom Herzog. I'm going to serve as the moderator for this morning's symposium. It's entitled Beyond the Image, New Opportunities in Gynecologic Cancer Testing. GOG and Natera worked on this together, so we want to get started and let you see what we put together. With me this morning is Dr. Stephanie LaRue. Stephanie, you want to introduce yourself? Say hi.
Yes, sure. So good morning, everyone, and thank you for being here early with us. I'm Dr. Stephanie LaRue. I'm a medical oncologist, and I practice at Princess Margaret Cancer Center in Toronto, Canada.
And you almost won the World Series.
Almost. Don't. Next time.
All right. And Dr. Katie Moore is with us this morning as well, but she's not quite with us yet, as you can see. So in terms of objectives, do we have a clicker here? Clicker? Yeah. Oh, there it is. Okay, thanks. You can see here, describes the principles of minimal residual disease testing using circulating tumor DNA and its application in GYN cancers, compares circulating tumor DNA-based MRD monitoring with traditional methods such as imaging and serum biomarkers. In other words, compare how you would test for cancer recurrence and what you're going to do about that. Third objective is to evaluate the evidence for circulating tumor DNA use in detecting recurrence and guiding treatment decisions in endometrial, ovarian, and cervical cancers. And then we're going to discuss some of the limitations, some of the alternative approaches and considerations for integrating MRD testing into clinical practice. Here's our agenda for this morning, and starting us off will be Dr. LaRue, Understanding the Science and Technology of ctDNA, followed by Dr. Moore, Clinical Applications in GYN Cancer. We do have a couple cases we're going to do, probably 3 or 4 cases. We'll do quickly to sort of show you how those work in the real world. These are real cases, and then we'll wrap things up. Next. And that kicks it over to you, Stephanie. Thank you.
So thank you so much, everyone. So it's an intimate group, so please do not hesitate as well to ask questions and interrupt if needed. So the idea of this morning was really to try to look more about beyond the imaging, and one of the big tools is potential of the circulating tumor DNA. So there's a lot of hotspot about circulating tumor DNA, but we thought that maybe we need to define what actually is ctDNA. So what is ctDNA? Actually, ctDNA, it's a small fragment that is released from the tumor. And if you look at the blood, actually, there's a lot of different elements in the bloodstream. So you have the normal RBC, macrophage, the normal cell. So actually, you have a lot of different elements in the blood. And here we really focus on the cell-free DNA. And what is cell-free DNA? Cell-free DNA is from necrosis, apoptosis, from the different organs in the body. And circulating tumor DNA is a fraction of the cell-free DNA that arises from the tumor cell. And actually, it's a very small component on the cell-free DNA. So it's usually less than 1% of the cell-free DNA. And the shedding of the tumor vary a lot. So actually, it's a very small component of the bloodstream. So it's why we will go after with different techniques how to detect the specific circulating tumor DNA. Because this tool actually is very potentially important for our patient because it's non-invasive, it could be very highly specific, and it's dynamic as well. Because we always talk about real-time assessment of biomarker, and actually when you think about biopsy, it's not very easy for a patient, but actually ctDNA gives us the opportunity to have a real-time assessment of what happened in the tumor in a timely fashion. And it's important to note that actually the circulating tumor DNA have a very short half-life of approximately 2 hours. So it's really real time. And ctDNA can be used for different aspects. And actually there's 2 different aspects where sometimes we talk about ctDNA, but they are different. So you can use ctDNA for the molecular residual disease, where actually you want to detect potentially cancer recurrence, but actually there's no cancer. And then after, you can actually use ctDNA, and we often heard about the liquid biopsy. So when we talk about liquid biopsy for ctDNA, is usually when you look at when the tumor is in place and you want to guide treatment, and you look at the genomic alteration of the tumor. So here is more to track the real time of the tumor per se. So here is what is ctDNA. So if we go more in the ctDNA application, so as we say, there's two big different applications of circulating DNA. And it's important to differentiate them because the technique that will be used to look at the circulating tumor DNA is different. So if you look first at if actually the cancer is not known if it's present or not, that is a category of the molecular residual disease testing. And here is actually to see in the adjuvant setting or if the patient will recur. And then it could be a risk stratification factor following, for example, complete surgery or adjuvant treatment, and also potentially to track the quick response to the treatment. You want to see if your treatment going very good, rapid response. So that is the technique of molecular residual disease, which, if you think about it, it will be a very different technique. You need to be hyper sensitive and specific for this specific test. If actually you know that the patient has cancer, you know that the patient has cancer, so it's a bit different. So here you're looking more at the tracking of the cancer, and you look more at potentially genetic alteration to guide the treatment. For example, if you look at high-grade serous ovarian cancer, you know that the patient has the BRCA mutation. Does the patient develop a BRCA reversion, for example? Or is the patient have the cyclin amplification? Or do my patient with endometrial cancer have a specific mutation? So here is a different concept when we talk about liquid biopsy. So the test will be used would be different. So if we look at the patient trajectory, so when do we want to potentially look at the molecular residual disease? And this concept of molecular residual disease actually came from him, because actually in solid tumor initially, we don't have this concept of maintenance really initially. So it was really the heme that was using this term of molecular residual disease, but it's coming in solid tumor now because of the maintenance strategy. So the MRD concept is actually to try to see if there is persistent cancer that we can detect after the treatment that is not seen by imaging. So that is a promise of the MRD for ctDNA, is actually currently we do not have tool to see if patient will relapse quickly or not, or if they need more treatment. So we need new tools. So that is a promise of the ctDNA for MRD. So that is currently coming in the solid tumor. And in addition, this MRD can actually detect more precisely the tumor burden level compared to the sometimes the CT scan. And specifically, when you look at the RECIST criteria for CT scan, we know that in ovarian, it's not very accurate. So we hope that with this new tool, you can actually have the assessment of the tumor burden more, much better. So now we will talk more on the MRD assay. So now we focus more on the MRD assay for the ctDNA, and actually what are the different type of the assay. So you currently have two big different type of the assay. So one can be tumor informed, and the other one is tumor naive. So it's two different type of analysis, and they have pros and cons. So first, on the first top here, you can see that you have the tumor that are tumor naive. So the advantage of a tumor naive assay is that you don't need tumor, and actually it's fast. So how that works, you have your blood draw, and then after you already have a predetermined panel and a hotspot mutation that has been established and can be utilized for different type of cancer, you often have to the genomic hotspot mutation, you often have also an epigenomic signature, what we call methylation. So it's not on the genomic level, but at the methylation level. So it's a kind of a panel. And then after you have your ctDNA that is detected or not detected. So that is a simple answer, yes or no. And the turnaround is actually 7 to 10 days. So it's actually very quick, and you don't need the tumor. In contrary, here you have the tumor-informed ctDNA, which take a little bit more time, because first you need the blood draw, but you also need the tumor, and then after you need to design your specific panel. So the advantage here is that it's a little bit more personalized to the patient because it's based on the tumor of the patient. But you have much time needed, so you have 3-4 weeks initially to design the panel, and then you have your turnaround of 7 to 10 days for the ctDNA. So when we look at the different MRD modality with the tumor-informed and the tumor-agnostic assay, do we have specific example in Gynae? Yes, there is some publication that has been presented with a different type of assay in Gynae. And you can see at ASCO this year, actually, the CALA MRD testing was assessed. And then also in the GOE ctDNA results were presented at ASCO this year. So these ctDNA tools are coming in the Gynae sphere. So here it's a summary of the circulating tumor DNA, because I talk a lot about the blood, but actually the circulating tumor DNA, because it's cell-free DNA from the necrosis and apoptosis, can be seen in different biofluid. So the blood is the easiest one, but actually you can have a biofluid collection to different area of your body. And specifically, if you think about Gynae, you can actually have ctDNA from the peritoneal fluid. But when we think about where is the most convenient, blood is actually very convenient. And why it's convenient? Because actually we need to ensure that there's no degradation of your cell-free DNA. And because cell-free DNA comes from the necrosis and apoptosis, so we don't want to increase the amount of cell-free DNA by just the process of the samples. So, for example, if you take the blood, there's a specific Streck tube that has been developed that allows to inhibit the leukocyst necrosis. So actually your tube can be stable and actually can be shipped. And this tube can be stable for 7 days. So it's very practical. So you don't have to store this sample in a precise way to have your degradation of your ctDNA. So that is why the blood is actually very practical and it's very accessible. And then after, when we talk about the assay of the ctDNA, we talk about the tumor-informed and then the tumor-naive assay. But then here, you have actually all the different type of the analysis that you can look at it. So it's opened a lot of opportunity, and you can see that sometimes it's actually very overwhelming as well, because we need to see that each test will have a specific sensitivity and a specific specificity, and that vary a lot depending on what you do and when we do it. So for example, if you look at the type of analysis, so actually we talk about the genomic, we talk about the epigenomic, but there's also some analysis that you can look at the copy number analysis. You can look also at the fragmentomic analysis. So it's a very different way of looking at the specific ctDNA. And then when we look at the genomic, the coverage of the genomic can vary. And you can have actually the whole genome sequencing. You can have the whole exome. You can also have a targeting panel of mutation. So really, when you look at the ctDNA result, you need to see how the test was done. And then after, the analysis methodology will vary a lot. You can have NGS-based, you can have PCR-based, fragmentomic-based, and that is important to know because the result will vary between the different tests. So in conclusion of this initial summary of the MR testing performance, I think there's several considerations that we need to talk about. So I think it's a very promising era in gynecological cancer. But we need to consider the ctDNA shedding. As we show initially in the first figure, the ctDNA come from the shedding from the tumor of the necrosis in the blood. But there's many factors that will impact the shedding of the ctDNA. So first you can have the tumor burden. So the tumor burden will impact the shedding of the ctDNA. And then you can also have the barrier, the physical barrier where the tumor is located. And then after you can also have the type of cell death. Depending on its apoptosis, necrosis, sometimes you can have a different shedding as well. So in terms of also when we consider what type of ctDNA do we want to do, it's also important to consider the tissue availability. So for example, sometimes it's easy to have tissue and sometimes not. So it's why sometimes we would prefer to have the agnostic ctDNA sample, knowing that sometimes we can lose in sensitivity. And another component that is important to talk and begin to be quite interesting is the clonal hematopoiesis. And you may have heard about the clonal hematopoiesis because of the PARP story. And clonal hematopoiesis is actually sometimes as a raise from the PARP inhibitor treatment. And clonal hematopoiesis may be the early sign of MDS. And is sometimes you can have actually clonal hematopoiesis and find TP53 mutation circulating in the blood. But that doesn't come from the tumor. Actually, that is an early sign, for example, potentially of MDS. So it's what we call the clonal hematopoiesis. So it's also very important to differentiate that and ensuring that when you report your ctDNA, you consider this specific CHIP mutation. And then after, when we talk about ctDNA, it's actually very important to look at the sensitivity and the specificity. And then it's very important to know, for example, when your test will be positive, the chance actually the patient will have disease. And the contrary, when your test is negative, the chance that actually is really negative. So all of that is actually very important to know, because if we want to act on the ctDNA, we need to have a good sensitivity and specificity for clinic. And then after, what we also need to know is that when we use this data, actually what really matters is the clinical outcome. So I think it will be very important in gynae to design trial to actually really assess a specific clinical outcome for our patient. So what we need at the next step in gynecological cancer is really the performance in clinical cohort, and to really assess the different assays in specific validated clinical cohort, and to really build that in our clinical trial design. And another important point that is important to consider is that the therapy-induced ctDNA suppression. So when we give treatment to our patient, you can actually really induce the suppression or even the clearance of the ctDNA. So when you think about the patient journey and the MRD, that actually is not only one time point assessment of the ctDNA. The serial collection of the ctDNA is important. So it's why I think it's, when we consider your clinical trial to assess the utility of ctDNA, yes, you can have that as a stratification factor at baseline, but then we will need to follow up with time the ctDNA to actually look at the specific endpoint. And when I look at the different tests, the different assays, you realize that it will be very important to actually have a standardization, because it's really important to know exactly what test do we use, and the reporting of the specific result will be important. So that was the introduction of the specific ctDNA. So I can take any question from now in terms of the, I don't, what? Yeah.
I'm Joel, a gynecologist. How often do you recommend to do this test? Does it matter during treatment, after treatment for surveillance? Does it matter if the tumor is squamous cell carcinoma versus high-grade serous carcinoma? Thank you.
Yeah. No, so it's a good question, because it's why I think it's why we need standardization even on the timing. So I think what will be important is first to have a baseline. So for example, if we have a baseline, we know what is, for example, baseline after the surgery, for example, and then you follow up with time. And you can follow up every 3 months, for example, and then depend the question. So if, for example, if you want to assess your response to neoadjuvant chemotherapy, for example, then you need first the baseline before you start, and then you're doing after first cycle to really ensure you have your decrease, and then you can repeat that at every cycle. So it really depends the question that you have. So it's very important when you design your trial or when you do this test of what is the answer that you want. What is your question? Because your question will drive the time point, and we also drive the test that we use. But I think and we will see some clinical example, I think, for example, if you want to assess the response to the treatment, you need to do ctDNA at baseline before you start the treatment and across different time points during the treatment. If you want to assess after as an adjuvant, then you do after your adjuvant treatment, and then you follow for the risk of recurrence.
But clearly serial testing, right, Stephanie, is going to be the way to go. I mean, we're just in the infancy of this technology, if you think about it. But we're going to show you some clinical data now, and I'll get started for you. That's really amazing in terms of when you test and how it affects those Kaplan-Meier curves and so forth. You know, they obviously get a lot smoother the more you test in terms of figuring that out. So, any other questions? Please. There's one. Corey, there's one over here too.
Oh. Thank you very much.
Corey,
you said the half-life is about 2 hours, and then the turnaround time is about 7 days. So once the specimen is collected, don't they get degradation or denaturing of proteins or whatever, so that you can get them maybe false value?
Sorry, can you repeat?
What I'm saying is once the specimen is collected, since the half-life is about 2 hours,
Yeah.
but the turnaround time is 7 days.
Yeah.
So I'm a little bit confused there that if you collect the specimen now, are you not going to get a false value in 7 days' time when you get the results?
So it's interesting because when you do a CT scan, I don't know how quickly you have the report, but in my practice, I have the report 7 days later as well. So I think it's 7 days is relatively quick, I will say. And I think if we can, so it's why you go back to the fact that the serial sample collection will be important. But if we test the patient at the end of, for example, cytoreductive surgery, and you have no result disease, you will have to repeat. But I think the recurrence will not be so quick. So I think the 7 days turnaround is actually relatively quick. I don't know if you answer.
Sorry, were you asking about degradation of the DNA? Is that what you were asking about? Yeah. So they put it in a preservative that it goes in right away, that freezes.
Oh, the preservation.
Yeah, I think he was asking about the degradation of the DNA.
So it's why it's actually a very good point. So so it's why it's very important to use a Streck tube. Because so it's a very good point because you're right. So as I said at the beginning, the cell-free DNA come from the necrosis, apoptosis, and there's so many different things in the blood. So it's very important to avoid degradation. So it's why you need to use a Streck tube because there's a specific component in the tube that allow the preservation, and you don't have the leukocytosis lysis. So I think you can actually ship this tube, and this tube can stay in ambient temperature for 7 days. So it's which is different when you use, for example, EDTA. So if you do ctDNA, I think it's very important to be careful of the tube that is used. It's a very good point. Thank you.
When there's asynchronous tumors or cancers present, do you have the science to decipher like a recurrence from which one it is?
It's a very good point. So I think it's where sometimes the tumor-informed is a little bit more sensitive because when you have a tumor-informed assay, you know exactly the type of mutation you expect to see on your ctDNA. But it's true, like if you have a different type of mutation, that you can raise a question if another potential secondary cancer arises.
Any other questions? Okay, Stephanie, thank you.
Do you want me to? No, you're good.
All right. I am not Dr. Moore. Dr. Moore got stuck in traffic. She stayed outside the city last night, and apparently she's been like 2 kilometers away with a wreck for the last hour. She should be here momentarily, so we'll go ahead and get going. So this is Dr. Moore when she comes in, so she doesn't have to introduce herself. She's at the Stevenson Cancer Center in Oklahoma City, in Oklahoma. All righty. So what are the clinical applications for minimal residual disease along the continuum of care? I think that's what's really interesting about this is that you can use it, if you think about the different cancers that we have, you can use it in very different ways to try to figure out that patient journey. It's also an opportunity to perhaps not only escalate therapy, but also to de-escalate therapy. So if you think about that. So you obviously have it around the time of surgery. And then when you follow the patient, you know, what do you do there? And I think one of the big things is if you think about endometrial cancer with IOs, for example, or you think about ovarian cancer with PARP inhibitors, should we really be using them for 2 to 3 years? How long should we be using them? So I think those are the things that we struggle with, and those are the things that I think this will help us tremendously. As you know, in the energy, we're doing a trial now looking at 2 years versus 1 year of PARP inhibitor, in this case olaparib. And so we're going to do ctDNA in that trial. The way we allocated it wasn't probably the best in terms of the number of times it's getting tested, so we're certainly looking at that to see if there's any way we can do better. But I think to have serial testing that's frequent enough, we could learn a lot about the natural history of the disease. And what we have found is that there's a tremendous amount of prognostic information that comes from minimal residual disease. How many of you people have used circulating tumor DNA in your practice? Yeah, so many of you have. Stephanie, you've used it?
We use it mainly as part of clinical trial for now.
Yeah, yeah. So I think that it's going to become much more common as we move forward, because I think this technology is really starting to show its ability to be not only prognostic but perhaps even predictive as well. And I think we're on the verge of something that I think we're going to transform care in many solid tumors, but also especially in GYN cancers. And Stephanie, you had said earlier that most of our cancers are shedders, right? Which is important. Obviously, if you have a disease that doesn't shed tumor cells into the circulation, that's problematic, and unfortunately, we don't have that. So you can see there, we can monitor for maintenance therapy, and then after maintenance therapy, you can then monitor for relapse of disease as well. So, do we need to start treatment for recurrence, and can we actually make a difference? So just finding out that the cancer's back 2 to 3 months earlier, that's good, but if we can't interdict and make a difference in terms of the outcome, that's not so good. So we've just created more stress for the patient without better outcomes, so we need to be able to prove that. Well, how reliable is this across different disease types? And as you can see here, there's published clinical validation data for a number of cancers: colorectal, breast, lung, bladder, and ovarian cancer. That's pictured here, but also for other cancers. And you can see, I think what's important is to pay attention to not only the sensitivity, but the specificity. Those go hand in hand. So you can make the sensitivity extremely high at the price of specificity, or opposite. What you want is that good balance that's going to give you the best parameters for predicting what's going on, but without too many false positives, too many false negatives, and that's really what's key there. So you can see the separation of those curves, which is pretty dramatic. And many of those diseases look like each other, because I think there's a principle going on here in terms of what we see. So the overall positive predictive value is 98%. Which is pretty amazing in terms of looking at this. So it's really quite outstanding. And you really do see that beautiful separation that occurs there. So it's very impressive in terms of how this is predictive across tumors, and how similar those curves really look across the different dynamics of the tumor. So I think, we talked about the energy trial where we de-escalate therapy with PARP inhibitor. You could think about doing that perhaps with checkpoint inhibitors as well, but you need reliable data, because you'd rather slightly overtreat than undertreat. So you're going to really need quite a bit of good data to be able to do that. But the fact that you're able to personalize the design is really important. You can also really personalize the assay. So if you're looking at really high, you want to make sure that there's high sensitivity or high specificity, as I said, you can set your parameters differently. And so that would be important as to whether you're looking for recurrence, where you might be okay with starting treatment, or you're looking to de-escalate, which is going to be a really high bar, in my opinion. If you have active therapy and you're taking the patient off, you have to be absolutely right about that. So I think that that's going to be a high bar to prove. So we'll see how that goes for those types of studies. But we may be able to better sort out who needs more therapy or who needs less therapy. And so you can see how that can swing between those two. And so you have the difference there as you look at that for the recurrences. So these are some of the opportunities to improve care with circulating tumor DNA and minimal residual disease or molecular disease. As you look across the spectrum, the journey the patient goes through in our particular cancers. So if you look at the big three, ovarian, cervical, and endometrial cancer, you can see here, and you can start to get an idea of how you would use this in practice. So diagnosis, that's a big one, right? Can you diagnose off of this? And as you know, there's companies that have spent a lot of resources on developing tests to try to do pan-tumor analysis for early detection of multiple cancers. So, where are we with that? And I think there's quite a bit going on with that. More to come on that. There's no FDA-approved test at this point for that. What about assessing for early response? So you can use this in the course of looking to see if things are working beyond the tumor markers and so forth that we have. And, we all have ovarian cancer patients, probably 20-some% that don't have reliable markers. So it might have been elevated a little bit, or you may have picked it up only after surgery. I get a lot of first CA-125s that I actually get at the time. They didn't get a CA-125 coming in, but they got referred to me maybe after surgery somewhere else, and now they're here to talk about trials or to start treatment. And what happens then is that we see that we're able to find out that they don't have a reliable marker. Well, it would be very nice to be able to, is that Dr. Moore? Excellent. So it'd be really nice to be able to know that that's working. Dr. Moore is going to come in and seamlessly do the slide. I'm already started on where we are. Katie got stuck in traffic. She is totally stressed out about this. She's like, I'm just going to sit in the back of the room. I said, no, you're not. No, you're not. Don't be stressed at all. We're all good. So we're going to go and talk about how you can optimize adjuvant treatment.
Okay.
With doing this. I've done your first couple slides, and you're good to go. Here's the clicker, and we're good to go.
To the disease site?
Yeah. Yep. We're good.
So you're pretty far in there. Well, I do apologize. I didn't realize it would take me 2 hours to get here this morning. But good. So I'm going to try and take over and figure out where we are in the slides. All right. So we've been talking about detection of MRD. And I think you've heard examples from several GYN malignancies. All of these are relatively small. I think probably Dr. Herzog already talked about the fact that this test is validated in breast, non-small cell lung, muscle-invasive bladder cancer, and we're interested in validating it clinically in gynecologic cancers. And so what would that look like, for us moving forward? We have some really kind of exciting examples of how this sort of technology really can be utilized to improve outcomes, both in tailoring therapy for patients who are at risk for poor outcomes or recurrences, and de-escalating therapy, which is also a kind of individualization of therapy for patients who just don't need anything else. We probably overtreat far more patients than we appreciate. So I'm going to show you this example, two examples. From muscle-invasive bladder cancer, and so kind of look at this and think about how you might apply this in settings like cervical cancer or early endometrial cancer, because I think this is the future for us. But this is in Vigor 011, and this is in patients with muscle-invasive bladder cancer. I know we're all GYN oncologists, but definitely we can learn from our medical oncology colleagues. And so these patients were enrolled after radical cystectomy, which sounds like a terrible thing to do to somebody. And these are patients who have, again, muscle-invasive bladder cancer and are felt to be at high risk for recurrence. And what this did is it looked at ctDNA following radical cystectomy or out to 1 year. So if a patient had positive ctDNA post-op, they went into the upper part of this figure into the randomization to receive adjuvant atezolizumab or placebo. And then the group that was ctDNA negative initially was followed for a year, and if they converted at any time during that point, they flipped into that randomization. If they never converted out to a year, they were just in observation, and then the group that was either initially positive or converted was randomized. So what happened when you tailored adjuvant therapy or not to a group that we already know is probably at high prognostic risk? Does intervening matter? That's the point. If I just know someone's going to recur and I can't change that outcome, then I'm just telling someone earlier that they're going to recur, which is sort of cruel. But if I can fix it, that's the goal. Did you fix muscle-invasive bladder cancer at high risk of recurrence? Yeah, you did. And so this is what happened when you guided atezolizumab to those patients who were MRD positive. This is MRD positive all, atezo versus nothing, and you can see a hazard ratio for disease-free survival of 0.64 means you reduce the hazard for the rate of recurrence by 36%, which is pretty compelling, but more importantly, also improved overall survival with a hazard ratio of 0.59. So 41% reduction in the rate of death events with appropriate use of adjuvant therapy in a high-risk group. You might say, well, what about everyone else? Did they recur later? Were they at risk for late relapses and you denied them this effective therapy that might have prevented their relapses? And it doesn't look like that. And so this is the group that's persistently ctDNA negative out beyond a year. Now, there are always some late recurrences, and so I think we have to keep modifying what we do because we don't want to leave anyone behind. But this is out beyond 2 years now, and we have, patients alive, 97% of the time. So I think this is an important sort of forward-looking opportunity for us once we kind of have this validated in our disease sites. This is just another example. This is similar disease group. This is muscle-invasive bladder cancer. This is Checkmate 274. Here they randomized, all comers. You can see patients who had received neoadjuvant cisplatin. These were kind of large tumor, high risk for recurrence, randomized to nivolumab or placebo, not gated by ctDNA. And so you can see that there is a disease-free benefit with nivolumab that's CPS positive versus placebo. But when you really look at the ctDNA, this is where you find the biggest sort of impact of using nivolumab in this population. So you can see in the blue, that's the Nivo detectable arm, and then versus the placebo in the detectable arm, like a huge difference there, really showing that the group who benefited from the nivolumab is the group that were ctDNA or MRD detectable. So you really could tailor this to a population who most needs it and not expose patients who aren't at risk for recurrence or at much lower risk for recurrence to unnecessary prolonged therapy. And so we can kind of think about this when we think about endometrial cancer. Endometrial and cervix are probably our biggest opportunities. Early stage endometrial cancer or resected node-positive endometrial cancer, we've been trying for my entire career, which is now spanning 2 decades, to identify those patients who are at high risk for recurrence and give them adjuvant treatment to prevent them from ever becoming advanced metastatic, which is not curable. And we've tried, there's so many studies, so there's just 3 listed here, and so I'm not picking on these 3. There's many others I could pick on. And I'm not throwing shade, it's part of these, and these were great studies, but we've really kind of failed to provide a risk algorithm that identifies patients who are at highest risk for recurrence and should get adjuvant therapy, and use adjuvant therapy that actually transforms those patients at high risk of recurrence into not recurring. We just quite haven't figured it out yet. Like, who are the patients who need adjuvant therapy? 1, who's at poor prognosis? And 2, what type of adjuvant therapy will fix it? That's what's missing for us in endometrial cancer. We haven't quite gotten to the point of changing outcomes for patients at high risk of recurrence. But we're working on it, and I'm just going to show you a little bit of data. This just was published, and so you can pull this down in the Journal of Precision Oncology, just came out this year. And this is a small, just a small bit of information that needs to be validated in a bigger study. But this was a prospective study, enrolled 61 patients with endometrial cancer. They got they had a postoperative single point test, and then some serial assessments of MRD. One group received adjuvant therapy per standard of care, and one group was observed. And this is just per that institution's assessment of risk. And you can see on the table on the right-hand side, the patients who were enrolled, 38% were high intermediate risk, 49% were high risk, so node positive, for example, and others. So this is the group of patients who, by our criteria, one group got adjuvant therapy, one group didn't. And I know the curves look a little different because it's small numbers, but statistically, it doesn't look any different. So the adjuvant therapy really didn't change outcomes as compared to the low risk, no adjuvant therapy group. And this is sort of what we've known in all those prior studies for time eternal is adjuvant therapy really doesn't work because you're probably over-treating some and maybe not even using the right therapy. When we pull out the ctDNA, this is where you start to see signals that you may be pulling out that group who really is at high risk. So the blue here is ctDNA positive. The green are the patients that are ctDNA negative, and here again we're talking about MRD. So irrespective of adjuvant therapy, in fact, 3/4 of the patients who were MRD positive post-op, which is 14% of the population, were kind of labeled high risk and got adjuvant therapy, and the adjuvant therapy didn't fix it. They were still very high risk for recurrence. So ctDNA does appear to be a prognostic marker in this group of identifying patients at high risk for recurrence with a hazard ratio of 7.6, so pretty high positive predictive value. This is just pulling out the ctDNA positivity post-definitive therapy, and you can just see, patients who, there was at least 3 or 4 patients who converted. They were negative, they converted during adjuvant therapy. All of those patients recurred, or in kind of surveillance post-adjuvant therapy, any patient except for one who converted to ctDNA ended up having clinical recurrence. So the predictive value positive seems quite high. And this is just looking at that longitudinal ctDNA detection by risk group, making the point here that the ctDNA in the small group, this needs to be validated, seem to outperform our traditional risk groups like TP53 alterations or others, histology. All those are important, but ctDNA seems to be potentially more predictive of the group of patients who's really gonna recur as opposed to these traditionally held groups. And this is just what I was mentioning by mismatch repair status, by TP53. These are important, but ctDNA may be kind of the equalizer in identifying more consistently the patients who are at risk for recurrence. In ovarian cancer, I think this is the same slide that Dr. Herzog had already shown. What are the critical questions in ovarian cancer? Well, they're much the same, although a little different. I think we all recognize that all patients need adjuvant. So post-op, other than an early stage, which I'm going to show you in a minute, you're going to give adjuvant therapy and you're expecting ctDNA positivity in advanced stage disease. But how much adjuvant therapy does someone need? More appropriately, how much maintenance does someone need? Could you stop maintenance early? If you surveyed for early recurrence, could you select patients earlier for secondary cytoreduction? Could you monitor response to innovative therapies early? There are a lot of questions that we still need to suss out in ovarian cancer. This is just one data set that I'm going to show you that was done as part of an early cancer detection study. So this enrolled patients who had high likelihood of cancer based on imaging or an adnexal mass. So not all patients had diagnosis of ovarian cancer that came into this. This pulls those patients out that did have cancer, but many of them were early stage and clear cell mucinous. It was one of those pelvic mass studies. And you can see that here, that quite a few of the patients were stage 1 and stage 2. So this does not reflect kind of a real world population of patients with advanced ovarian cancer, but just to show you kind of what they found. This is there's 69 patients, 44 of them were in this group of tumors that used archival patient samples, and then there was a cohort that looked post-op, and then another cohort that looked at kind of serial samples post-adjuvant therapy. The point being here that the pickup rate, even in early tumors, interestingly, and late stage tumors was about 33%. So I think we have a lot to learn about MRD positivity in ovarian cancer, because early versus late, it was 33%. Irrespective of that, though, if you picked up ctDNA, and this is the kind of post-adjuvant and longitudinal sample cohorts that I'm showing you here, it did identify a group of patients who are at high risk for poor recurrence-free survival. You can see that here in the red curve is the group that were either were ctDNA post-adjuvant or picked up positive ctDNA on surveillance. So it does look to be prognostic. And when you compared this to CA-125, it appears to be a better predictor of recurrence. And we know this from many of our platinum-sensitive studies where patients could have recurrences that were clinically evident and have normal CA-125s. And so the importance there is that you could potentially miss the opportunity for a secondary cytoreduction, if you were just relying on symptoms and CA-125. If you pick this up with ctDNA, would it enable you to intervene, if you believe in that, a little bit earlier? And so it's not surprising that it may outperform CA-125, but then the question is, what do we do with it? And then the last group is cervical cancer. This is probably where we have the most robust data for kind of utilization, at least thus far, for MRD and ctDNA. And here kind of the spaces, if you had a patient with early stage cervix cancer or local regionally advanced cervix cancer who's getting chemo RT, how do you know who's cured? A lot of those patients are cured with just what you have done. Do they need 1 or 2 years of pembrolizumab, or can you just stop? This might help us identify the patients who do need more, just like that muscle invasive bladder cancer. I think this is the most analogous setting. Recurrence monitoring, does this help us pick up patients early that we may need to flip to? Again, in the muscle invasive, the IMvigor study, it was ctDNA out to a year. So and then you added the atezoin and they did very well. Should we be doing that in cervical cancer? Just watching and waiting to see if they convert and then bringing in an immune checkpoint inhibitor. That's a novel idea. And then you can look at early dynamics in the metastatic setting. Again, we've seen this in surveillance monitoring for patients with cervical cancer. These are very small kind of data sets. This is 21 patients. And you can just get a sense on the right-hand side how you monitor, kind of patients over time at these different time points, what they've received with chemotherapy and radiation, and the dynamics, this is only 21 patients, but the dynamics of clearance of ctDNA and then reemergence of a signal of ctDNA and how that impacts or relates to clinical progression. Very small numbers, guys, just so this is not definitive data yet, but just to give you a sense, you can see on the left-hand side, this is post-therapy ctDNA. If a patient never had a recurrence, it's 11 patients. Only one of them had positive ctDNA at the end of their therapy. Everyone else had cleared in that no recurrence group, versus in the 2 patients that had events, they were both positive. In the surveillance after adjuvant therapy, that kind of first month after, in the patients that had no recurrence, they were all negative. In the patients that had an event, 1 patient positive. So you can kind of see the pattern here. We need to validate this, and we are seeing this data come out in CALA and other studies to really know how to utilize this over time. I've already mentioned the sort of utilization of this as a kind of predictor of patients whose tumors are going to do poorly, and then we can potentially flex up or down therapy. That needs to be validated. The other place is treatment monitoring and trying to assess for a tumor that's starting to creep back, which is important if we have something to fix it with. Otherwise, we're just telling people earlier that they're going to recur, which again, I think could be cruel. But with novel therapeutics, you can imagine a world where we identify something early, you bring in an effective therapy, and you do fix it for a while. So I do think this is important. We can't just sort of say we've been there, done that with CA-125. It's just earlier recognition of recurrence and more treatment for a patient with no impact in OS. That was true 15, 20 years ago. That may not be true now with better drugs, better therapeutics, and more targeted therapies. So we need to revisit this idea of, if I find something early, does my intervention matter from a survival standpoint, or is it just kind of time ascertainment bias, and my patient still unfortunately passes away on the same day with more therapy? This is what we need to figure out. We know from these studies that I mentioned already that CA-125 is just not enough to detect early recurrences, and half the patients on these platinum-sensitive PARP maintenance studies had clinical disease because we were scanning them without evidence of it on CA-125. So it's just not enough for monitoring. Becca Aaron and her team at the University of Alabama looked at this again in another small sample size. This is 45 patients with 156 longitudinal plasma samples, patients that were on PARP inhibitor maintenance therapy. And just looking at what did it tell you as opposed to CA-125. So on the left-hand side, you can see outcomes for patients that were that converted to be ctDNA positive or were negative versus CA-125. And so small numbers, but the predictive capability of ctDNA for telling us that this drug isn't going to work in a patients at high risk for recurrence, and these are patients in the recurrent setting, so not frontline, but it outperformed CA-125. And perhaps that's not surprising, but maybe something that we can utilize in clinical practice moving forward. The other place where we struggle to monitor patients outside of kind of platinum-sensitive maintenance settings, should I use this, should I not, should I change, does my patient need this? The other setting is immunotherapy, and so this is not an ovarian cancer problem, at least not yet, but in endometrial cancer and in other settings where you're using immunotherapy and you don't know that it's working. Maybe you're like, is this a flare? Is the lymph node just bigger because it's full of immune cells, or is this drug really not working? I don't know. I'm going to just keep giving this and see, 6 or 8 weeks later if it's working. Can we all do that with immunotherapy? The pseudoprogression can be hard to suss out. The INSPIRE trial looked at this. This is all solids. And mostly kind of triple negative breast and lung and others, but it is informative to look at. It's about 100 patients receiving single agent pembrolizumab, and they tried to figure out whether or not ctDNA could tell you early whether or not the immunotherapy was working in settings where clinically you just weren't sure. And the answer was suggested that it was. And what you can see here is that PFS and OS among patients with ctDNA values at both baseline and week 6 that were positive versus those that remain negative was markedly different. And in patients that had detectable baseline ctDNA and at week 6 still detectable ctDNA, even if they didn't have objective progression on their imaging, none of them went on to respond to the therapy. So it's perhaps an earlier marker, and I'm showing you here just the OS of responders, non-responders, who's going to be an exceptional responder. Maybe the CT doesn't look that much smaller, but you've cleared the ctDNA. That gives you some confidence that you should continue the medication because maybe you, even though your CT doesn't reflect the disease, is responding. The fact that you've cleared ctDNA in a setting that was positive, something's going on there that's benefiting your patient in settings where biomarkers and imaging sometimes can be misleading. So I think this is an interesting opportunity for us to also think about using ctDNA or MRD dynamics to better adjust our immunotherapy for our patients. And with that, I'm going to turn it back over to you for cases.
Great, Katie. Can you bring me the clicker?
I will.
Come on over here. All right, we have the next slide. Perfect. Great. So I'm going to quickly go over a couple cases. I want to leave a little time for questions. I think that's why you fine folks got up early this morning. Want to ask some questions of the faculty here. So this is a 72-year-old who had a stage 3C high-grade serous ovarian cancer. It was HRD positive, folate receptor alpha positive as well. She underwent primary debulking surgery to no gross residual disease. Postoperatively, she started carbopaclitaxel and Bev for 6 cycles and received maintenance Bev plus olaparib. And the green indicates a PET CT scan, and the orange there is her CT scan of chest, abdomen, and pelvis. It shows a 15 by 16 millimeter retrocaval lymph node. So at that point, she began mirvetuximab. And it's a real case. What we're trying to show you here is how you can get these time points and show the difference and how well it correlates with what's actually going on. And so you have the confirmatory things that you use in your everyday practice, your physical exam, your tumor marker, and you have, of course, imaging. So you can see there how that all works together in terms of the dynamic. But I just think this is sort of a nice example for the faculty to, I don't know what you think about it, but it just sort of shows nicely how you can get down there. Not a completely happy case, as you can see, you get the countdown very low, but it was on time point 5 there, it was really quite high still, even though you had a decrease, and then it's falling to 0 there. What do you think the odds are of that staying there, Stephanie?
So I think it's why we need the serial collection sample.
Yeah.
And I think it's really show as well that the MRD can be used to track response as well to the treatment. Actually, MRD can be used, so it's why going back to the question we had initially is how to use MRD, and actually will depend on what is your question. Do you want to detect the recurrence earlier? And as Dr. Moore was mentioning, how can we act on that? That would be the next trial, that how we can act on detecting the cancer recurrence earlier. But then after, I think what is also interesting is that actually can also use that to actually track the response, and much quicker and easier probably for patient.
Yeah. Let me just get to a second case here. So this is a 67-year-old with stage 3C high-grade serous left fallopian tube cancer. Sort of the same thing that you see here. You can see the primary debulking there at the beginning. The orangish red triangle there is PET CT. But you can see here carbopaclitaxel Bev followed by maintenance Bev. Spike during maintenance is when that happened. So maintenance was stopped and went on to platinum-resistant regimen with weekly paclitaxel and bevacizumab times 9 cycles, with a very nice response down to 0. You can see the time points there where there was 0 mean tumor molecules detected. So what do you think of this? Obviously a happy story, Katie, but in real life, real case, what do you think?
Yeah, you know, I think this is a great example, Tom, because it illustrates the things that I worry about and also I like. So let's start with the worry. Should we be using a ctDNA flare to change therapy right now in absence of clinical or imaging progression? We don't know that. Certainly with CA-125, with bevacizumab in particular, I don't tend to change if someone feels great and the CT doesn't illustrate progression, because really there's never been anything that's shown that me switching early matters. And so do we still believe that or not? I think is something we have to constantly pressure check ourselves on. Like with new therapies, should I be changing earlier? Tom, I remember you, gosh, it's been a while now because we're both a little older, saying ineffective therapy is ineffective no matter when you use it.
It matters what's in the toolbox, right?
It matters what's in the toolbox. And so that first flex to something else, I'm like, was that the right decision or not? Or could have you gone a little longer off chemo? The second thing, though, that I'm interested in is I love the fact that they use ctDNA here, MRD, when they're on weekly Pac-Bev. When they get to 0, and they've been to 0 for at least almost 4 time points now, 0.04 to 0, they de-escalated the chemo. And that's a nice thing to do for a patient if we're sure that that's a good thing to do. What was driving that response? Was it the weekly Pac or the Bev, or did you reinduce a response? But I don't know, I think we have to be careful using these sort of examples of going, oh, I'm going to do that now. But I like the idea of using this to de-escalate how much chemotherapy I'm exposing a patient to over her lifetime, so I can have her be healthier. Because I think that may, in and of itself, may help her live longer. But I think this is a nice example of where there's still a lot of tension on, okay, I have this piece of information. Now I've made my patient worried because she knows her ctDNA's up. But I'm going to say I'm not going to do anything about it. What do you do in that scenario? So this is an interesting example, I think.
Well, I think you bring up a really key point, and I was going to actually ask the audience and the faculty here, what does all this mean if we were doing this 10 years ago? We wouldn't have had near the tools, right, to deal with. Look at the recurrent ovarian cancer, for example. I mean, we have Murph, thanks to you and others. And we have a number of other regimens that are probably going to get approved in the next 6 months or less. And so it's a really exciting time that we have these showing OS, even improvements in OS, and we saw the recent data from B96. So I think that's the exciting part here is to look at this. So it's been a collision of the technology coming along at the right time, in my opinion, where our tools are developing.
Yeah, but I think is that as a first case, we can actually detect recurrence earlier, but the question is what to do. And I think we are still based on the Rustin data, saying that actually based on the CA125, if we treat, was not impacting the overall survival. But I think maybe it's time to maybe challenge that, and maybe rethink of, given the concept of MRD, and maybe re-challenge, and maybe ctDNA can be a tool to see how we can target and how to target actually this molecular result disease. Because I think it's now the question, we can detect it, but how can we target it clinically that will impact clinical outcome?
Yeah. This is a case of endometrial cancer, but we have a question here, and I'd rather get to the questions. So
Thank you. I just wondered, is it possible that at time 10 and 11, when your marker is 0, that the DNA, the tumor DNA, changed, and that for that you cannot detect it?
what do you think, Katie?
I mean, I think that would be frightening. But tumors sort of humble us as they become more subclonal, and there's so much tumor evolution, and this is a bespoke assay, so they are using the tumor to define the test that's being looked at.
So this is tumor-informed,
Tumor-informed,
Yeah,
right?
Right.
So I guess that it's possible. I think as we start to look at these over time, that'll be something we're going to have to reassess. Do we need to biopsy and then re-look at the kind of ctDNA to see if we're not picking up the change in the clones? I guess that's possible, and it would be a reason for continued negative ctDNA in the setting of clear clinical progression. Right now, we sort of attribute that to tumors that just aren't shedders of ctDNA to pick up. But I honestly would have to say I don't know the answer to that.
Yeah, I haven't seen a lot of false negatives by the way things are set, but is it theoretically possible? It certainly is. And I think you're right. I think we'll need more data on it. Yeah.
And I think it's also where the tumor informed is actually usually it's more sensitive. But again, it depends on the metric that is used to assess the tumor informed. Do you use a panel? Do you use whole exome? So I think again, going back to the initial presentation is how this test was done, tumor informed, because you will have different answer and different sensitivity. So that's why it's important to assess that.
Yeah, we've got several other cases, but I'm going to take chair prerogative here. We're at time, so I want to allow any other questions from the audience, because I think that's much more important than me presenting a neuroendocrine cervix or vulvar cancer.
Thanks. So, is this working? Yeah. I wonder if we've let the genie out of the bottle of how we sort of evaluate this. Do you think we will ever be able to formally evaluate this in a blinded, randomized fashion as to whether such an approach leads to an improvement in overall survival? It might, I don't know, but it might also be analogous to how you get a flight from Chicago to Cape Town. Multiple different ways, and in the end, you're going to get there. It's just a question of how. And I'm a little concerned, we've seen this before, that the technology gets so far advanced and accepted that a randomized study becomes impossible.
I think other disease types were able to do it. So I really hope, and I hope it will be feasible. And I think given how many maintenance strategy we are looking for right now, and if you look, for example, of the ADC trial coming up with maintenance, so I think we really need to encourage the ctDNA stratification, because that will be the answer. Because to do maintenance strategy for everyone for a lot of time is not the right things to do. So I think if ctDNA MRD can be the tool that actually guide this treatment strategy.
That's a great question. It's an excellent question, though, Al. I think that you're right. I do think, though, that we're at a stage right now, if we can get these trials started, where we can do types of trials that were done in muscle-invasive bladder, where you saw the data that you showed with the atezo addition, interdicting. And that's the key question, right? So everything we have in GYN so far has been prognostic. What we need is predictive. And we need to move on to that, and we need to do those types of studies, and a number of people are looking at those and trying to embed them. So I'm optimistic that we can do it. I don't know.
Yeah, I'm optimistic as well, but I think you're absolutely right. And Al, I think you're spot on. Some of you may have been in the audience at ASCO when they presented Serena 6, which is sort of the poster child for using ctDNA to inform development of a resistant clone and then switch and show that that improves outcome. And just like everything in breast cancer, where they have so many more patients, the standard of care changed, and so when the results came out, everyone was like, yeah, but if I find an ESR1, do I just tell my patient she's going to die earlier? Do I not do anything? You know, there was a lot of equipoise from our breast medical oncologist when that came out that I'm not a breast medical oncologist. I looked at it and was like, this is amazing. And they were like, no. So it's like that kind of nuance with what you learn from this, and then what you can do with the information to change outcomes, that we are not quite there yet. The endometrial story is a great one. Yep, I can tell you that someone's high risk with ctDNA. But if I give them Taxol carbo, that doesn't fix it. So is it a rainbow type approach? If I find ctDNA, you get a PARP. If I find ctDNA, you get an immune therapy. If I don't, I'm going to leave you alone. That study I think we can do. Like you just said, a de-escalation, these big, you know, can I find a BRCA reversion, can I find a this or that, and then randomize. I don't know feasibly if we can do those studies because our numbers are so much smaller than breast and colorectal and others.
And I talked about the de-escalation trial that Energy's doing with Labra before you came in. I think that it's just that the bar has to be really high, right, before we're going to take an active therapy away. I mean, that's just a really high bar for me. All right, I think we're at time. Any other questions from the audience? All right, I want to thank you all for attending. I want to thank our faculty this morning. It's outstanding. Thank you. Thanks for coming this morning. Appreciate it.